feel free to ask anything you want also, because that's what y'all here to learn also a little bit about some of the new stuff. Most of them heard me talk about dry eye. So interrupt me anytime you want. I'm going to go through some boring slides that will just show you a little bit about dry eye, and then we're going to get really down to what it's about. If anybody, I'm going to be here. If somebody wants to talk to me one-on-one afterwards, rather than feels less comfortable in a crowd, feel free to say, I'd like to speak to you one-on-one. Just remember this. When we talk about dry eye, this word multifactorial. Dry eye is a very complicated disease process that gets worse over time, and it's all about inflammation, discomfort, visual disturbance, and tear film instability. So, you know, just throwing a drop in your eye, we know, has never helped, never worked, and it's just something to get by with. We know that 20 to 30 million people in the United States suffer from dry eye. So this is nothing that is new to you. Cassie, who will have it done tonight, suffers from dry eye. Half the people in here, everybody would love to have this done, but this is not. It's an expensive procedure, and everybody has to save up to have it done, even in our office. The important thing that we're going to learn is that there's different kind of dry eye. It's called lipid deficient, and that is what we're going to work on. That's where the treatment starts. And I'll go through that a little bit. And we have aqueous deficient. Think about this as oil, and think about this as water. Without the oil layer, this water layer evaporates, and then the mucin layer causes the mucus in your eye. And that's why you wake up sometime, you have crusty feelings. That's why it's the end of the day, it gets worse usually, unless you don't close your eye at night, because during the day, as eyes open, if you don't have enough lipid, the aqueous just evaporates off all during the day. And that's why it gets so much worse in the afternoon, unless you have lag ophthalmos, where eyes don't close all the way. That is much more prevalent than we thought before, and then the oil melts out at night. But that's a different treatment. We're going to do this test. We're going to have each of you and any staff that wants, we're going to do a lipid test, and we can really test what your lipid layer is. Unfortunately, at the end of the day, like you are today, and you've touched your eyes, some of you may test fine. We like to do this first thing during the day, and we like to do it with no drops has been in the eye, and you haven't pressed on your glands. Because if I do this, I now have more oil in my eye than I had before I did that. And this test is so sensitive, it'll pick all that up. But you wouldn't be here if you didn't have some symptoms in dry eye. The other thing that people don't realize with dry eye is that you're looking through a tear breakup. The tears break up and light scatters. So you don't see well either. Every time you blink, you can see that things clear up. When we're doing an exam on patient staff, and we say, which is better, one or two? And we ask the patient to blink, we already know they have a dry eye. Because when they blink and the vision changes, they have a dry eye. The tears are breaking up on the eye, and it causes you to have this blur clear all day long. And that's what also contributes to dry eye. These are the lipid glands. These are the openings of the lipid glands. You can see this nice white oily substance. That's what it's supposed to look like. And you can see they get blocked, and then the oil gets blocked, and then you have decrease, and then you have the symptoms. These are normal glands. So you can see they run just like this on the lower lid and the upper. You have about 30 on the lower and 40 on the upper. Some people say 30 and 20. It just depends on the person. And this is what is now considered the #1 cause of the majority of people's dry eye. And you can see this, how nice and uniform. And this is a patient that shows that half of them are gone, and they're getting all scattered. And look at that. Half of these are gone. Now, a patient like this, we know, will never do as well as a patient like this that has blockage from these versus blockage from these, because these are gone. And I'm going to show you some real patients at Schaefer Eye Center that had this issue and that we've worked with. So you can see the dropout of glands right there. And this is a schematic of shows that's normal. And as you start progressing, it gets worse. And one thing about dry eye, everybody here, no one gets better without treatment. Everybody is going to get worse. And that's why we try to catch it early. There's a new group that's been formed at the University of Houston that I'm fortunate to be part of, and we're meeting in February to rewrite all dry eye treatments for the world. Because what happens, we're treating people at 50, 60, and 70 instead of at 30 and 40. If you have a dry eye, it started when you were 30 years old. The problem is that's what you look like at 30. Now you like this, and we're treating this versus treating that. So we really, there are somewhere between 12 and 20, I'm not sure how many are on the new committee. We're going to do a 2-year study of rewriting everything that's ever been written about dry eye because of what's happening with the meibomian gland discoveries. So, you know, in our office, we do history, we do all the stuff to get you to that point. But let's talk, you have irritation, you have burning and stinging, discomfort, itchy eyes, sandy gritty, blurred, tearing, intolerance, blinking frequency of mucus discharge. Raise your hand if you have any one of those. Now watch this, turn around. Raise your hand if you got any one of those symptoms. This is so prevalent, it's everywhere. And these guys are not like me. These guys are 30 years old, well, a few of them. Not many anymore. Sophie, what happened to you? Sophie, you over that? I know Dr. King is way over that. So. And we know the factors is increasing. As you get older, it gets worse. Any female on hormonal changes, you're getting a dry eye, 80% dry eye. If you have allergy, look at anything that has to do with the environment and any type of medications. There's so many, anything, blood pressure, antidepressants, cardiorhythmia, birth control pills, antihistamine, sleeping pills. You know, everybody here, everybody in this room is on one of these. And this is one of the key causes of dry eye. We have these great meds, but they all dry the eye out, especially allergy meds. So when we go through a dry eye evaluation, and I do literally a 2-hour lecture to doctors 4 times a year, and we average about 200 people per course on how to do a dry eye evaluation. And it is literally a 2-hour lecture to doctors that do this every day, just how to do it right. And so we use all these different things that I have lined up on this table, so you can see that even in a normal dry eye evaluation, we're using lots of different pieces of equipment. It's not just what probably, and again, I'm not trying to slam doctors, but I do all the time. The average doctor does an eye exam. You give them an insurance card, and they don't even do a medical. They do a exam for glasses, and they say, here, take this drop. Use this drop. I'll see you in 6 months. That's just bad medicine. And I tell them all the time, a dry evaluation is a 20-minute visit by itself. It should never, ever be done with an eye exam. To staff out there, I know there's a few doctors out there, never, ever, ever be done with an eye exam, because there's so many different things you have to do to look at, because if you're going to treat a dry eye, you better get to what the true diagnosis is and what are you treating. And that's what all these tests are about. And now we have this, which is really the state of the art, the newest test, and we have the new treatment devices. This is all the things you can do with people who have dry eyes, from LipiFlow, which is the best, to nothing like artificial tears, warm compresses, eyelid scrub, puncture plugs, oral antibiotics, oral supplements, steroids, Lacrocerts, allergy drops, topical antibiotics, moisture trained with goggles, compounding serum, liposomal spray, duct probing. I have to read all this. Pulse light that I don't believe in, that's a new thing too, but I don't believe in that. Restasis and blinking exercise. I mean, that's a lot of stuff. It's all on that table, and that's the things we do. And so again, here's a true eye that looks, and all these glands are blocked. And I'm going to show you what happens when they get like this. As y'all know, I'm just going through some of these quick. These are all the different over-the-counter drops that you can put in the eye. There's very few there's a couple like this new Sustained Balance is good if you miss an oil, or the Allergan Advanced. Everything else, it's all the same. And everybody's, you may like one, you may like another, but they're just an artificial tear to make your eyes feel better. And you know how long they'll stay in the eye? Anybody want to guess? How long does a drop stay in the eye? Any must-have? Less than 3 minutes. So unless you can put a drop in the eye every 3 minutes, it's gone. Put it in, it's gone in 3 minutes. The new thing also is, and we put a lot of our patients on this, is omega-3s and a special dry eye. You can't just use any omega-3. It's got to be a correct EPA to DHA, which is about 1,700 to 300, and you want to use very high quality omega-3s because it's got to be absorbed into the system. A lot of us take omega-3s and half of it just goes right out. Comes in, goes out. And to get to the eye, you really need a lot of omega-3s in the eye. Restasis, the #1 drug. Love this drug. We use it on every, I wouldn't say every, 90% of our patients is on Restasis. Are you, anybody on Restasis? Just you? 1, 2, 3, 4, 5. How often are you using it? 3 times a day? You're good. I mean, most people don't do it. You what? Yeah, I know that. I'm one of the few people that do it 3 times a day because the study says twice, but all the new studies, it's a long story why they did that. And how long have y'all been using it? How much? Twice? Yeah, and that's what the studies all came. The reason why they went to twice a day is the way the FDA works is you're supposed to use it and throw it away. Nobody does that. Well, you may, but most people use it in the morning, use it at night, and then throw it away. So if they went to 3 times a day, it gets really expensive. I probably shouldn't be saying this on tape. But we go to 3 times a day because you already got it sitting there. Why not use it? It's a great even the vehicle. The vehicle is what the drop's in. So cyclosporin is in something called Endura. Endura used to be its own artificial tear, and it's a great artificial tear. So why not use it 3 times a day instead of having using 2 different drops? And that's why we use it a lot 3 times a day. But you got to be on this drop for a lifetime. It doesn't work until you're on it for 6 months. It doesn't even work at all. I mean, you don't start seeing effects until 3 months, and we have slides to show that. And that's 1, 3, and this is their slide. This is Allergan's slide that shows you it takes 6 months before you really even start seeing symptoms. And if it's the only thing you're using, you're not going to have it either because there's other things that have to happen with it, including punctal occlusion. Anybody got plugs in? Okay, you have plugs in. And plugs are great, but you have to put plugs in after you've treated everything. And you got to put the right kind of plugs in. If you put plugs that go down inside the eye, they sometimes cause more problems than the ones that sit on top of the eye. And the ones at the top of the eye, you really need to take and remove every year or so because they get so much debris under them that they're actually pretty ugly to look at. Lid scrubs. We know now that we got to keep the lids clean. The problem is that these lid scrubs burn, but that's another thing for you have anterior blepharitis, another type of dry eye. So sometimes we'll add lid scrubs to this. Azicite, which is almost went off the market. It's the only drug that was made for meibomian gland disease, but they never got FDA approval to say meibomian gland disease, so they had to sell it to Bausch & Lomb, and Bausch & Lomb, other than the company that used to have this, they would say anything. Bausch & Lomb won't do anything that's not FDA approved, and they're not allowed to say this is good for meibomian gland disease. But it's azithromycin. It's a anti-inflammatory type antibiotic. Antibiotics kills bugs. Anti-inflammation kills inflammation. Those are steroids. This acts like a steroid on the lid. That's what we think why it works. So we use it sometimes, not as much as we used to. Oral doxycycline. Doxycycline is an antibiotic, but we know that long-term use of antibiotic, like 60 days, 3 times a year, helps the lipid metabolism. It helps break down something called MMPs, so now your lipid stays in. But the problem with doxycycline, you really got to stay on it for a long period of time. 60 days, and you get off for 60, go back on for 60, and it's one of those things that I personally we put somebody in to start. I mean, I put you on it, but now we do that, and then we add the omega-3s, because if you take omega-3s and the right ones for a year, it has about the same effect as doxycycline. Our goal is to stabilize your tear, increase lubricity, which is the movement, the softness of that, and increase tear production. So again, let's look at some of our patients. So these are meibomian glands. You can see they're blocked, and that's called capping. Those are glands that do not excrete anything anymore because they got little caps on them. These are the glands that are running right through there. And I would bet that every one, if I inverted your lid, that's what you're going to look like with these blocked glands. Everybody got that? And they see that? So everybody knows here, 8 years ago, this patient would never have been ever stopped about doing anything. We didn't know anything about this 8 years ago. These are my patients that I've had for years, and I should have fixed this 20 years ago, but I didn't know about it. No one knew about it. And so now we know, and we're looking, we find all these problems that people have. That's a capped gland, so nothing's coming out of there. This one's about to be capped, that one's about to be capped, and you can see how red this lid is. So we take this, and I put a paddle behind it, and I express this lid. I'll show you what that is. Well, this is like a paddle. It's a smaller one. And we put one of these behind the lid, and I test the lid. Or I take this and push it on the lid, and we want to know what comes out of this lid, and look what's coming out of there. A nice toothpaste-like thickness. Well, obviously that's not doing a whole lot of good keeping oil on the eye. When I keep pressing, look at what comes out of there. That's not mucus. That's my Meibomian gland that is now coagulated and turns into this toothpaste-like substance that blocks all those glands. This is called frothing. What happens is right before these glands block, and I'll show you some more of that, they start creating acids, and that's why a lot of people used to be put on baby shampoo, which is the worst thing you can do to an eye, the absolute worst thing, because it's already making soaps. These are soaps that are being made by whatever's left coming out of there with the tears creates a soap, and now a lot of people put people on baby shampoo, which is just soaping something that's one of the problems of the eye. And we just found that out, and you see these are frothing. These are those soaps coming out of each one of those Meibomian glands. This is what you want to prevent. 90% of people have lid disease. As they get older, they're going to start having indentation in their lids like this. And that is from atrophy of the gland. Here's more. And you can see multiple striations of indentations in individual lids. Every one of these are patients at Schaefer Eye Center. And by the way, every one of these are patients I've probably been seeing for 20 years that I could have prevented this. But we didn't, because we didn't do anything. For those staff in other office, when you're not treating these patients, this is what you're going to cause when they get older when you don't treat them early. So again, let's look at that divot right there. You invert the lid, and you can see there's a block gland, and there's the divot right there. And look, there's no gland. It's dead. It's gone. It atrophied. It went away. And so what happens? The tissue falls down because there's no tissue there. This one's right there. Look at this one's about to die right now. If we don't do something, this one's going to die, and the person's going to have 2 divots in the lid. So you get the capping like I showed you. Oh, no, that's not what I want. And so does everybody see? I'm going to go back to this slide. I put that one out of order. So what we do is what we did up until 3 months ago, and again, this LipiView and LipiFlow instruments were just invented about, well, guys have been working on it since 1980, but they just came into market about 18 months ago. It's brand new stuff. I've been wanting one for a year, but it's $100,000, $99,800 to buy this unless they went up again. I don't know. Where's Nick? Have they gone up again or no? Okay, is that what they are? Yeah, $99,000 to buy this equipment, and we got to pay every time we use it. But before I did that, we used different tools, and so there's a very normal looking lid, but you take one of these tools, and this one, you're going to see this one in a minute. Well, actually, this is called the masking expressor. I take this tool, which I graduated. This is the newest, best tool. It's Dr. Stephen Maskin in Florida invented this. And you hand roll the lids, and look what comes out of there. This eye is very normal. I bet you 60% of people have eyes that look worse than this, of those young people sitting there. And you express, and this is what happens. Now keep watching this. That's what, the harder you press, the more it comes out. The problem is you can't press hard enough because you can't deaden the lid enough, and you can't heat this enough to get out. And that's why we're going to show you that we still do this. It's the step before. Did you have this one done first? And it's the step before we had the LipiFlow, and it's still good. It still works. And for those that don't want to do LipiFlow, I'm going to show you how that works too. We still do it every single day. In fact, I like doing this 6 weeks after I do LipiFlow again, but now the glands are working better, so it works better. You can see that's what comes out of another patient. Now, this we see all the time. This is discharge. That's a hard toothpaste coming out of that gland, and the more I squeeze, it keeps rolling up. And look at this, it's rolling down the entire lid. That gland would have been gone in the next year, because look how blocked up. All that was blocking that gland that came out from that procedure. And unfortunately, I couldn't heat it up to do that. The next procedure is called masking probing, and it's this tool right here that's got this tiny little needle on the end. And we actually, this is your eye gland, we actually take that needle and probe it down into the gland and open it up. This procedure is also one of Maskin's procedure. That's what the eye looks pretty bad when you finish, and it hurts. This is very painful. That's why we don't do too many of them. It's $500 per lid, and before we had LipiFlow, and that's what we had to do because that's all we had. And I still didn't like doing this because, like I said, it was extremely painful. I want to go back and show you one thing. Oh, this procedure, by the way, because I did want to go, that is a $300 procedure that we charge $289 plus $25 for the mask, and it covers, but any visit after that is $68. Then you have a copay on top of that. So it's about $400 or $500 to have that procedure done when you're finished. And again, it's there, we have it. It's just not even in the same ballpark as what I'm going to go through right now. So before I get into treatment with LipiFlow, well, let me do that, and then we'll go through questions. Okay? Does anybody have questions of the dry stuff? My staff, part of my staff. Any of y'all want to stop? Or you want me to keep going and show you the rest, and then we'll talk. Okay. So, what do we look for to see if you're a good candidate? The first thing you want to know is, do you have signs and symptoms? You know, that's. Some people have symptoms, some people have signs. Signs means I see it, symptoms means you feel it. What we really don't like to see is when you have symptoms and I see signs, we know we got a problem. I tell every dry eye patient when we do a dry eye workup, and this to the staff, this is not a 1 or 2 visit. This is going to take you 4 to 5 visits minimum. You've been through it, and that's what it takes to treat a dry eye. It doesn't just go away. This is something you have for a lifetime. What we're trying to do is control it, get your eyes back to normal, make it a little bit better. But these people, are, you know, these eyes, it doesn't go, this is a progressive disease. You either treat it or let it get worse. And if you treat it, all you want to do is keep it where it is, in the same place. The next thing now we added, we can assess your tear film with this LipiView. And you'll see that done. We can measure the thickness of that lipid layer. And the last is we really got to do a great meibomian gland evaluation, because you know that 85% of all dry eyes are caused by MGD, meibomian gland dysfunction. Kelly Nichols, a friend of mine at the University of Houston, that put this other group together, did the TFOS study. If y'all haven't been, you need to go to the website, TFOS, Tear Film and Ocular Surface Disease. It's from Harvard University, and they have 65 doctors from around the world that did this study over 5 years. And the study showed that 85% of all dry eyes came from MGD, and they changed the name from disease to dysfunction because it sounds so bad when you say, man, I got meibomian gland disease. Well, I want a little dysfunction. I don't want disease. So they actually changed the nomenclature of what it is. All of y'all have filled out this dry eye questionnaire. Every dry eye workup should have a question. This is one of the 3 questionnaires we use in our dry eye workup. This is called a speed. We use this one, and then we have also a grading scale. We let you grade how dry your eyes are. So we go through a grading scale also, and that gives us a great idea for y'all that saw this one. The other one's a little more complex. What you see, what we feel, and how you feel about your dry eye. This is the LipiView machine that you will see that shows the measurements. Y'all going to see that demonstrated in a little while. Y'all saw this. This is how we test. And the person who invented this machine also, he's a unique guy. His name is Donald Korb. He's in Boston, at the Boston Eye and Ear. And he came up with this. You can press this on a lid, and you can tell immediately if someone is expressing enough. And it doesn't take much. If you do that and they don't get an expression, we know they're starting to develop meibomian gland dysfunction. And this guy's an amazing guy. He lined up 200 patients and had an engineer build this out of this massive machine to show how much pressure does it take on an average healthy patient for them to have a discharge out of the meibomian gland that's clear. And that's how this was made. A year to make that one device. And it showed how bad this dysfunction is among even young people, because when you start doing it, you can see how bad. But all this is testing. LipiFlow is what this is all about. When I first saw this instrument, I said, I got to have one. And then they came out with the price. I know this guy, Dr. Korb in Boston. I went and saw it in his office. And he said, well, wait, you'll be able to get one. It came out and it was $100,000. And I said, I'm buying that for $100,000. I can buy a new house for $100,000. Not really, but but watching it done over and over and hearing the people that are doing it is one of the things at Schaefer Eye Center. If we're going to be number one in dry eye, we have to have this piece of equipment. It doesn't matter how many we do. For the people that need it, we want it done. And by the way, as I go through this, I tell every patient who has this done, this is the greatest spa you've ever been through. I had when we went to the trial, I had one eye. They allowed us only to do one eye, which after having one eye done, I said, I'm not leaving until you do another eye. I'm not leaving this room. And there were 12 of us, 12 doctors in the room when we went through the study. And I said, I'm not leaving. And all of a sudden, every other doctor lined up. We're all not leaving. And we made them do our other eye to show us the piece of equipment. So this is a warmer. This goes inside the eye, as you can see here. Okay? So this is placed inside the eye. Your eyelids then go between this bladder, which is right here. Here's one for y'all. Look at this. There's one down here you can pass down and look at. By the way, these are not going to be used. So these are ones in my eye, but they've been sterilized. But you can't ever use them again. But you can see. Oh, I need one when y'all are, so I can keep showing you as you're passing it. So this will be placed in the eye. It is extremely comfortable. Now, we deaden your eye. We actually anesthetize your eye, but I hate anybody touching my eye. When I was a student, people got me because when we were students, we had to work on each other. Everybody hated getting me because I wouldn't even let them touch my eye. I had one eye done with anesthetic and one eye without, and it was great. I mean, I love the one without because I could feel it a little bit better. No pain, no discomfort, because it doesn't rest on the cornea. It rests on the sclera that has no feeling. There's no nerve endings there, so you don't feel this. And then you have this that's heating, and it feels so good. Cassie, how does it feel? And then we have these two bladders that they are then filled, and those bladders are what pulsates. These bladders pulsate, and that's what actually pumps the meibomian glands, and they roll up your lid starting at the back. So I think I have a picture of the lid. So when you see an eyelid, and these are the meibomian glands, you remember when we do that expression, we have to heat the lids for 50. We make you wear a mask for 15 minutes. Not with this, with the expressors. The problem is the heat's got to go all the way through all this tissue, including something we call a tarsal plate that's pretty stiff, to heat back here. Well, that doesn't get a lot of heat. We know it takes 105 degrees to melt this tissue, the meibum. By having the bladders back here, the heaters, it's right next to the gland, and we can get up to 105 degrees. It's measured, and you will watch when we have Cassie done. You'll see the instrument go up to 105 degrees and heat that, and then you'll watch it being done. Now, let's go back to that LipiFlow dry eye questions. What do you want to know? Anything?
How many treatments does it take?
Great question. The LipiFlow takes one treatment. It lasts 12 minutes per total, but you have in each eye. It's 12 minutes of treatment. The actual treatment time is 12 minutes. Obviously, setup time, and there's no pain, no discomfort, and you feel wonderful when you finish. But you have one treatment, depending on where you are. If your glands are half gone, you would need another treatment in probably 1.5 to 2 years. If you've got a lot of money, you're going to want one every year, because it's just, I want one every 6 months. I just love it. I mean, just sitting through and feeling your eyes completely open. But we tell patients that, this is some people one time and that's it. It's done. What it's doing, it's draining your glands, and then it's teaching your glands how to work again. Because your glands, they're there, they'll work. But they're not going to work if they haven't worked in 6, 7 years. They're just sitting there not working. So this is actually massaging the glands, emptying them, and getting them working. That's why we have you back, and that's why even though I can't do that in 6 weeks, I go ahead and express you again, because now it's easy. I don't have to press so hard just to watch and see how the glands are working, because it takes about 4 to 6 weeks for you to really start feeling the major effect, although some people feel it within days. I mean, Cassie will tell you, we did one of her eyes, and she immediately called the same thing I did and said, you know, you should do everybody one eye, because now my other eye hurts so bad. I didn't realize how bad it hurt. Is that what you said to me? And she said, why don't you let patients do one eye at a time and let them feel how good it is. Well, it's a time for you have to come back 2 separate times. We're happy to do it, but we know what it'll do. So it's easier to do 2 eyes at one time, and you don't have to have 2 separate visits to do that. So the treatment's 12 minutes for the actual treatment time, and it could last you anywhere from a year to a lifetime.
So does that eliminate restasis and all that other stuff?
No. We have had, there's multiple patients that have stopped using drops. Absolutely. I will not take you off restasis. Now, what restasis does, there's something called goblet cells. I don't know if I have a picture of an eyeball. This is good enough. There's something called goblet cells. This white of the eye is filled with goblet cells. Goblet cells help produce other things in the tears. And we know as we get older, those goblet cells gets destroyed. There's only one drop that will replace goblet cells, and it's restasis. So when we start this treatment, like I said, there are plenty of people say, my eyes feel great, and they want to stop. We do not want you to stop a drug like restasis, because I think restasis really does a lot of good. But that's the only drop you should have to use. Now again, let's say you have grade 4 dry eye. And I don't know where y'all are yet, but if grade 4 dry eye, you're going to still have ointments at night. You know, it may do everything. But let's say you have a grade 1 or 2, restasis is all you're going to need. This does not change that. That's why we do that entire workup. We have to know each part and what part you need personally, because every one of you will have a totally different treatment pattern. Let's say you don't close your eyes at night. You have lack of ophthalmos, so you have thyroid eye disease. May I use you as an example?
Sure.
If you look, see how exposed her eyes are, how large, as opposed to have a lid lower. I know that her eyes are going to be drier than yours, where your lid is more in a normal position.
But I'm older.
You're not supposed to say that. How old are you, 42 or 43? Okay. That's my age. I mean, you can lie. I lie.
39 and holding.
There you go. That's what my mother used to say. The more you expose the eye, the more it's going to dry out. And you can see, like, her eye is a little bit, can I ask you that? Do you have thyroid issues?
I've never done anything to my eyes, and I've had this condition for a long time. I don't put drops in them, I don't do anything. So I'm here to learn.
Good. Well, that's, thank you for being here, and we will teach you. And we will do a workup at you at some point in time and tell you where you are, because I can tell that you have a dry eye. Yes?
What about patients with Sjogren's
What about patients with Sjogren's syndrome? And it's funny, because Sjogren's syndrome is one of the most underdiagnosed diseases there is. Sjogren's syndrome is an autoimmune disease where the lacrimal gland starts destroying itself. So if with Sjogren's we start seeing a lot of aqueous deficiency along with, I'm running on battery power. That's okay. About finished. This is a patient with Sjogren's. Oh, there you go. That's Sjogren's. Okay, so this stain right here, what we do when you put these dyes in your eye, anytime you have dead cells or dry cells, it stains with this called rose bengal. This is a lot stronger stain than what we use fluorescein, but that's why we always use 2 stains. For y'all staff back here, if your doctor used just fluorescein on dry workup, you need to tell them, you need to go see Dr. Schaefer, because they have to use 2 stains. So in a Sjogren's patient, you get an extremely dry eye, and you always need treatment. You guaranteed to have a dry eye. Do you have Sjogren's? Yeah, and so you may have meibomian gland disease. You may have something even more so, but that's how your eye will end up, that dry, if you don't deal with it at a younger age like you have. And you'd be surprised how many people today have Sjogren's. In fact, there's a new test that's just been invented that we'll be able to pull your tears and you can be tested for Sjogren's. No, you hadn't had that, because this is brand new. This is coming out in about the next 2 weeks, where we can actually test for Sjogren's by looking in your tears and not just in your blood. And by the way, there's a new test for diabetes too. We can look in your lens and tell if you have blood sugar issues. Any other questions on meibomian gland disease, dry eye, anything, staff. Any questions y'all have? Yes.
So is there any cutoff that you feel like it wouldn't do any good, like if the glands are all dead?
Yeah, absolutely. So if you saw that last, if you see that there's no glands, there's no purpose in doing it, because you know, if you have 3 or 4 working glands, it's a good thing to do because you want those to work because that's all you got left. But if you got no glands, we had a phone call today from a patient that Cassie is sitting on my desk that you can answer that patient. No, she doesn't need to have it done. I have a patient that's no meibomian glands left, so there's no purpose in doing a LipiFlow on someone that's had a lot of lid surgery and all the meibomian glands have been destroyed.
So does lid surgery destroy people's meibomian?
It depends. You know, it depends on. They definitely. At any time, it depends on what type lid surgery. Not the skin, but if they're going into the lid, yes, like a tarsiaphy or they're changing the structure, yes. Any other questions? Okay, so we're going to go now. We're going to watch a LipiFlow. You're going to do LipiView on y'all. Now remember, you may have a normal because if you touch your eye all day, you're going to have some oils in that eye. And then we're going to demonstrate actually a LipiFlow on Cassie and let you watch the whole procedure.
This test is really doing 2 things. First of all, it's allowing the patient to see what the doctor sees. This is one screening that a doctor will do during a whole dry eye evaluation. This technology called LipiView is doing 2 things. It's showing the doctor the quantity of the lipid or the oil, and it's also testing for partial blinks. Now, when I first heard about this, I'm like, what are partial blinks? Most of us think that we blink fully all the time. This screening test allows us to see if a patient more or less blinks full or not. Patients that don't blink completely basically have more dry eye symptoms than others. Okay, so what this allows us to do is actually look at Joy's right and left eye here, and it's going to measure, okay, the quantity of lipid, and also is going to show partial blinks. So when we look in this eye right here, see partial blinks 1 out of 8. So in that 20 seconds that test took, 8 times, okay, she blinked. 1 of those was a partial blink. When we move over to the other eye, we have the 8 blinks as well. 5 of those were partial blinks. That's important. When a doctor reads this, he's going to educate a patient about this, and then he's going to continue to go on and do additional testing. So
hold on one second. I want you all to see
Sure.
how light is breaking up on this white part of the eye. I already know that she's going to be dry right there instead of seeing a smooth surface. So there's a lot of things we see also. But go ahead on.
So basically, the doctor will then look at the numbers here, and it calculates, and it kind of gives him a grading system. So right there, he kind of sees that, educates the patient on that, puts that as a permanent, in their file. They could have a copy of this as well. And then from there, he's going to go ahead and look closely now, just like those pictures you saw up on that screen, at those glands. And he's going to actually grade those secretions that are coming out. They should have secretions, if they haven't died or atrophied, that are clear like olive oil. If they're not, he's going to grade those, and he's also going to see how many glands are working, how many glands are clogged, and how many glands are dead. And that is where the whole education comes into a patient to see if they truly have this MGD, meibomian gland dysfunction. He'll then let you know if you're a true candidate for the LipiFlow technology, which is the actual treatment of this gland dysfunction that we're going to have and be able to observe next.
And this basically, again, is just like a big
Y'all wanna
contact
come watch
lens.
us go in. Come over, just walk.
Is it at the same, both eyes at the same time?
Like the same
Yes.
thing.
Typically,
Yes.
yes.
Usually the same.
She does.
Yeah, y'all come over. I'll get all.
Don't be shy. We're family here.
Come on in there. That's fine.
You can watch in the office. It's got to show up. You see, now it's totally, how does it feel, Cassie? Talk as you're doing it, if you don't mind.
No, it doesn't hurt. It,
You're supposed to say it feels great. I mean, it doesn't
him
hurt.
putting it in does not feel
Hasn't gotten to that
great.
point yet.
Is it in?
No.
Say so. I don't even know.
So you remember the drawing, so you can see it's in her eye. So now we tell them that you will hear, first you're gonna hear sounds. And first it's gonna, if y'all come around and watch the screen, I want everybody to see the screen. It's because you're gonna see as it starts turning on, it's gonna start heating up. That sound you hear, that's air going into the bladder, and she can feel a little bit of squeezing, but it doesn't do anything yet. And as she hears that air, it's gonna warn, okay, now it's coming, and you feel this, and it just feels very good. So you can see it's at 98, 99. Look at the bottom right. It's telling you how hot it's getting on that. Can you feel it? Is it getting warm? What are you feeling now?
I just feel it warming up.
I know you got to sit back and enjoy the last one. You're going to have to talk during this one. They want to know what you're feeling.
The only way that I could describe it after having my right eye done was when you've been here all day and your eyes are on fire and you go home and you get a really hot washcloth to where you're gonna burn your skin and you put it on your eyes and it feels so good for just a few seconds, but then it cools off. It feels like that for 12 minutes.
So you see she's at 108.5 degrees. And that's what we have to, all the tests showed you have to get it 108 degrees in order to melt the modern through the lids. But it's
It
protected.
doesn't feel hot
It
on
just
your
feels
eyes.
warm. Oh no, it feels.
It feels like a hot washcloth.
Does anybody else use the bead mask? I use it
Yes.
twice a day.
Oh, no, they do that. Everybody, yeah, we want you to use that. The problem again with masks again, you got to go from the
Yeah,
outside
but
in.
it's real hot at first, it cools off
Yeah.
real fast.
And like I said, we love the mask, as you know.
So would that be something you would do after one of these LipiFlows? You'd have them use the mask regularly?
No, because you don't
Not
have to.
necessarily?
We've already melted.
You know, I would have to do that anyway.
No,
How about sleeping with the cute little,
with the water glasses I have on.
no, just a little, it's just a little mask you sleep in. Just a-
The one I gave you, the mask. Yeah, you don't need. Now again,
Well, I have a CPAP though, I don't know.
Yeah, that's the only thing with CPAP. I don't want that air blowing in your eye. So I would probably leave there. Remember, everybody's different. So
Yeah.
she has a CPAP machine, it's a sleep apnea machine, and the air blows into your eye. Remember I said about drying your eyes out? So we have her in a sleep mask that keeps the air out of her eyes.
Was it massaging you?
Now
I
you'll hear
can
it.
start to feel like a little bit, but it's not really good.
So what are you looking at when you're looking at the screen? What's going on there?
Oh, well, I don't care. I'm not looking at anything. We can see this is, it's showing the time, it's showing how many pounds per square inch. You can see it's going to climb in a minute. And you'll hear, it'll start saying, you'll hear, zzz, zzz. Y'all will hear it in the machine as it starts. Right now it's warming up the gland and just slowly squeezing. As you don't feel the slow tightness. She's going to feel that it starts pulsating. It actually rolls up.
So
Starts to
do you actually get stuff coming out of the glands
Oh
from
yeah,
this?
it's draining the whole
Wow,
body
and where's all that go?
into the tears and just they get dissolved. Remember, it's already heat up. It's liquefying that modern.
So
And that's what it's supposed to do.
so if I could chime in, so basically what this device is doing now is it's unclogging those glands. Now you realize these glands that are clogged haven't worked correctly in a certain period of time. So not only are we liquefying that oil, then we'll start to clear it out. And as this device continues, and you'll hear it start to do multiple pulses here shortly, what it's doing is it's ideally just using warm heat to squeeze the glands, sucking out that clogged pore and really starting to get it working the way it should. Post-treatment, each and every day, that gland, you got to realize it hasn't worked in probably quite some time. So now it's going to start working.
You can see right now it's growing in pressure on her eye. As it starts stepping stone, you'll start hearing it now, and she'll tell you. Tell us when you start feeling the pulsation. There's one right.
You can actually hear it.
That's what, boom.
Actually pulls it out and it goes back into your eyes.
It's really
Melted.
an eye massage.
Melted.
It really is. And the patient, just like Dr. Schaefer said, they're just relaxing. 12 minutes, their eyes are shut. They're just kind of chilling out there. Some offices play soft music, some light a candle. It's really a spa-like experience. One thing I'd like to add is as soon as this 12-minute treatment's done, that patient can resume normal activity that day. Drive a car, go back to work, go out, enjoy their day.
What it felt like or meant to not be aware of your eye. I guess that's the thing to me. Like, I'm not aware of my right eye anymore. Whereas I was constantly aware of it before 3 weeks ago. So I'm really excited to not be aware of my left eye. Because then my left eye started bothering me way more than my right.
This is the only one in Alabama. This is the first and only one in a year. And again, I wanted it a year ago. I mean, I've had this done. Mine was done over a year ago, and I saw this a year and a half ago. But I couldn't pull the trigger on spending the money. And then, again,
So, right, because of the cost, that is something that's a big factor. Not only
For
for your
me and for
practice,
you,
but also
and
right
for
for
the
the
patient.
consumer.
Insurance
coming in,
ever
so-
pay for it?
no. Because, especially with affordable care, they're not going to add any new procedures that elective procedures. They just won't do it. And the company doesn't even, they're not even trying to, if a company's not behind it, they can't even do it because right now they're selling every unit they have. I mean, there's a waiting list to get these units. So if anything.
And you can use care credit though.
Yeah, so we have a care credit card where you can do that. And like I said, having,
So will the procedure be administered by a technician or actually a doctor?
a doctor always places the lens in the eye and removes the lens out of the eye. A technician will stand here. We always have an assistant and someone's always in the room with you. And right now there's just 2 or 3 because everybody's watching it get done.
So what side effects, if any, could someone experience?
None. There's not been one single side effect reported through the whole FDA study and through the 100 units that are out there around the world today. It's probably 70 in the United States, 30 units are outside the country that were placed in the original